Well, we've got, with your permission, about another 15 minutes to kind of share some thoughts about what you've heard today, things that has kind of prodded you to think about, questions that you might have of each other. I know you had a chance to talk over lunch just for a few minutes, but you may not have gotten a chance to ask the right question as the right person. So I have some thoughts that I would like to ask or share, but I don't want to do this, so I'm going to hold those and get from you. Our featured kickoff speaker has something to share or a question to ask.
Just a few things that I would ask along the way. I was going to give a quick answer to just some folks want me to talk about the NPPA, what the future of that is. How are we moving away from physicians to more NPPAs? And in general, my thought process on this is yes. We're seeing more and more acceptance, a lot of pushback from physicians at times, but the trend is moving in this direction. I think 10 years from now, we'll be sitting in this room and we'll have more NPPAs working closer to the top of their license than we do today. So that's sort of the future of this. Now, if you're
does anybody disagree with that? Any doctors in the room? Disagree with it?
I'm
disagree
sorry.
with the notion that we're going to become more and more reliant upon nurse practitioners and PAs.
And they'll be working closer to the top of the license 10 years from now.
Probably not that.
You think I'm going to strike back at you?
I hope you would, yeah.
No. There is no way that we will solve the issues in rural health without a more advanced role of nurse practitioners and PAs working at the top of their license. Despite what we try to do in terms of new medical schools, expansion of medical schools, and everything else that we're trying, as a medical educator, and I've spent
A long time.
a damn long time at that. As a medical educator, we will never turn out enough physicians to meet the needs of this country. We will never do it, okay? And we've got to come across, we've got to realize that, and we've got to realize that we've got to provide the health care. So we have to use the other resources that are available to us in order to accomplish that. I can't say that any more strongly.
Okay, great. So are we all in agreement then that part of our advocacy efforts have to be able to make sure that we've got funding to educate advanced practice nurses and PAs in these environments? We all agree on that? Okay, legislation's coming up soon. Next.
Well, I think the status is, if you're a hospital CEO, and this will happen in my office tomorrow, is I will have a physician that will come in and tell me, you know, physicians are better trained than nurse practitioners and physician assistants. You know I went through more schooling than they did. You know that. They're not doctors. And I don't know why they're yelling at me about this, but they're yelling at me about this. As soon as they leave, a nurse practitioner will come into my office and say, I am trained for more than what you're allowing me to do in my hospital. I'm trained to doing this. I'm trained to do this. If that's what's happening, okay, that's today's state. That's exactly where we are. There's a tremendous amount of tension. Both parties think I don't respect them enough. And that's just kind of the way it is. So if that's where you are today, that's where everybody else is. Don't feel bad about that. So, another thing, and Robin hit on this quite a bit, and I think Beth hit on it a fair amount, and it was a subtle undertone, but I want to make sure it's solid out there. There's this huge division between academic medical centers, tertiary, quaternary care facilities, and rural hospitals. We don't always respect each other the way we need to. A big shock to everybody out there. But what we ended up finding out is the big thing is, how do we develop the trust between the two? And I'll describe a situation we had at Margaret Mary a few years ago. When we have a patient come in with a cardiac arrest, now some of you guys think about what's happening in your hospital when a patient comes in with cardiac arrest. They have an arrest out there, the ambulance brings them in. They may come with a paramedic, they may not. I think this patient's having cardiac arrest. We repeat everything, we draw labs, we assess what's going on, we figure out, yes, this patient's having an ST elevation myocardial infarction. They have got to get to a cath lab. There's nothing I can do at my hospital to cure this patient. They either need surgery or they need to be in a cath lab. So we call any number of different places. Do you have a response? Do you have a cardiologist available, or do you have a preference of where you want to go, to this hospital or that hospital? Oh yes, I want to go to this hospital. We call the cardiologist on call. who the ER doc goes and takes care of another patient while that cardiologist is calling back. What's going on? Have you tried this? Do you know what's going on here? You run a 12-lead EKG. Let me take a look at it. Transmit that EKG. All right, it seems like this is what's going on. Meanwhile, the nurse is calling a helicopter saying, we've got to get this patient out of here. Do you have an accepting hospital? Not right now. The ER doc is talking to the cardiologist. Hasn't accepted yet. Okay, call us back when you do, because we're not going to send a helicopter out until you have an accepting facility. Now we've got an accepting facility. Now the helicopter will launch. Now they'll come in, they'll pick the patient up, transfer the patient. So the helicopter's doing a round trip. We come in, they go into the receiving facility who repeats everything that we did, because they're not going to operate on this patient based on what we had to say. Everybody did a great job all along the way, all within their scope and all what they should have done, and it cost that patient healthy heart muscle. We ended up creating a partnership with a cardiology team where our paramedics identify an ST elevation myocardial infarction in the field, they guarantee acceptance. We looked at what it took to transport that patient by ground one way versus helicopter round trip, and it was much quicker ground one way. So that patient can either go direct or they can come into our hospital, we'll draw the labs, we'll confirm the EKG, and we'll send them straight on. We actually are 45 miles away from the cath lab, the very closest cath lab. Our average door to balloon time, when the patient gets our door to the cath lab, is 110 minutes. To when they came in our door to when it's cleared blockage in the cath lab. We've actually beat the on-call physician to the cath lab before. And now the cardiologists at the hospital in Cincinnati know when it's a patient coming in from Margaret Mary, they've got to hustle to get to the cath lab. They don't have time to do that. But that took building trust between the EMS service, between our nurses, between our doctors, between that cardiologist at the referring facility. The answers are not going to be inside your facility. They're going to be what you build outside of it, and a lot of people have touched on that today, but I want to make sure that point is really clear. A lot of our jobs are building trust within this. It's not about building a great house, it's about building a great community. I think that's sort of where this is. I lectured too long on that, I'm sorry.
No, that's great.
I wanted to bring that point
How many
clear.
of you are experiencing difficulties with upstream referrals from your facility to the bigger one? Fair enough. How many of you have an easy process for those facilities to send them back to you as swing bed patients? How's your occupancy going? Good? Is it working? You got anything to share, Kim, on what's working, why that works easily?
The main thing is to cut down on the steps and the processes in between the referring hospital and the department. Because if you've got a long wait time between the time they make the call for the referral and the time you actually say, yes, we'll take the patient, they're going to go somewhere else because you've got 5 or 6 out there waiting to take the same patients. So what we've been able to do, just recently we implemented a APP hospitalist program because we only had 3 physicians in town and they could not take call for the swing bed patients, their rural health clinic, and the hospital. We were just burning them out. Couldn't recruit physicians because we couldn't get them to the area because they were going to have to take on call for the ER, plus have rural health days to meet there in the clinic. So we've gone to an APP model that works under a supervising physician who is our emergency room physician, so we have someone there 24 hours a day. And that APP, along with the supervising physician, can turn around and accept us on a swing bed patient within like an hour. So that's been great for us. We're
Within
3
a
months,
what?
An hour. We're 3 months in.
You hear that? Anybody can beat that?
But currently, we're 3 months into that process, and it's going great, as my CFO says.
That's extraordinary. So the Peach story talked about the success of filling up swing beds. The services that are attached to the swing bed patient, just much like Robin talked about, the services that, it's not just about the long-term ventilator care, but it's the services that are attached to those sorts of things that allow you to expand and grow that and give you a steady revenue source. Those rapid turnarounds on swing beds work not only for you, but they work for the sending facility as well, right?
Correct.
And because it works once, and I'm not going to ask her to show her cards on how many times she hits that 1 hour, but I bet it's nearly every time. Because there's not a lot of barriers when the information is exchanged and the nurse practitioner or the PA who's there is incentivized to say yes rather than, I'm tired. You know, those sorts of systems make that the first call. And the only reason that they would say no is if they don't have a room. What other kind of things have you thought about today that you think, I've got my list, and I've still got about 3 or 4 minutes here, but I want to make sure we get from you what you've heard that might, God, that was really good, that's something I could do.
I want to ask you a question. Tim, you talked, one of the issues that a number of places have dealt with is the issue of the emergency room and an urgent care facility. And the fact that, so as you pointed out, 10,000 of your patients, of your 20,000 patients go to urgent care. You know, they're not what we might classify as emergencies, but they're emergent to that patient. Okay? But there's been a real issue with doing that in the fear of violating EMTALA regulations. You mentioned that you had both the emergency room and the urgent care. You came through the same door for both.
Right. Yeah, they're actually the same facility, and we really didn't. What we've done, I think, is a great model. It has not been a financial success. It doesn't violate any rules or anything like that. But what happens if you come into our hospital, you're triaged either to our minor care or to the ER. And you can go in the same room for both. It's really a paper process. But the charge you receive, if you have a minor care level of service, is comparable to urgent care anyplace else. I mean, that's as simple as it is. It's not a separate door or anything like that. It creates problems because insurance companies still look at it as an emergency department. So regardless of my charge, they want to charge the patient a higher level copay, they want to charge the patient a higher deductible or something like that. So that creates the problem. I think it's a great model. It works out really well for us, but it was a financial loss for us because before we had kind of like 12 or somewhere around 15,000 visits to the ER, and they all got ER charges because they're all ER patients. We looked at that and said, for the best thing for the community, we need to cut these level charges down, describe it to the community for what it really is. You get kind of triaged urgent. Now, if you come in with acute abdominal pain, it may be a minor care, it may end up being surgery, but it doesn't, you know, it's one of those things that what ends up happening to you is not your diet, not what you think coming in. You just, if you would have gone to the urgent care for acute abdominal pain, you would have ended up getting transferred to us if it was appendicitis or an acute kidney or something like that. So that's how it works for us. We think it's a great model, but there's no good reimbursement model for it, and there's still these problems with the insurance companies of how they look at it. I've seen other people create it where it's got to be a separate physical address, and then you've got the EMTALA issues that you deal with, and hey, you want to sign out here. There are some models where you put a telemedicine with an MA in the lobby, and it's like, hey, it's going to be a longer wait and a larger charge, but we think you can be taken care of by this. Would you like to use this minor care service? There are a lot of people looking at some creative things like that. I don't know how the billing works for that. I still think it has to be a separate address. Sir?
Real quick, Bob.
Sure. This is purely a hypothetical question, but curious if people think it would be useful to have a one-day in-place board educational retreat that was brought to your institution.
So that was not a question for me, that was a question for y'all. Would there be any, would you see it as useful if there were one-day on-site educational opportunities for your board members?
Yes.
Absolutely.
So one board member spoke up, one's walking out the door, bye. But I know what her answer would be, because I know Dr. Lattimore very well. I'm another board member. So that's actually where I was going to head to try and wrap up, and thank you, Dr. Nesbitt, for that, because we do want to be respectful of your time. I've shared my anecdote as just a dumbass general surgeon from South Georgia who was attending board retreats that I could spot the hospitals that were going to do well and the ones who weren't, based on engagement of the board. When I worked for the State Hospital Association, because I was the doctor for the State Hospital Association, all the CEOs wanted to come talk to me about how do I get my medical staff more engaged? How do we get the doctors engaged? How do we get the doctors engaged? And one of my frustrations was that I felt like, you know, you got this board sitting out here too. You live in between two spheres. You live in between this board sphere and this medical staff sphere, whether you employ them or not. Doesn't matter. But you live in between those two spheres. Executive comes from the word execute. You're carrying out the strategy. You're the ones who are supposed to be executing the strategies developed by the board in concert with the medical staff to do whatever it is that's on the wall. And most of you people have mission and vision statements somewhere on your wall that says it's about improving the health of the community. You might use different words. It's not about having a 3% margin. That's not on the wall, although that should be a part of your strategy. That's a goal. Maybe it's 1.5, whatever it is. But my challenge to you is, as most of you who are here are executors, not board members. Despite my own observation, the study that was conducted that led to Augusta University developing this whole Center for Rural Health Support study was this notion that strong boards deliver on the vision. And so what we want to know, this is your opportunity. If you won't share it out loud, that's fine, but we ask you to fill out these evaluation forms. What is it that can be done that you would see as valuable to help you with board engagement and education? We've done some pilots of some on-site day-long education sessions. I think they went pretty well. I don't think we got it down to a fine science. At GHA, my favorite event year-long was the Trustees Retreat. We had Patient Safety Summit and Trustees Retreat back-to-back every spring. I still think it's like the best 4 or 5 days of every year. But following the Patient Safety Summit, where we had all the patient safety teams and quality team members around, following that with the trustees, man, it was like a revival. I was on fire. I was going to the board members telling them how great their teams were and what they needed to be learning as board members about what their teams are doing back in the hospitals. So that's one of the things I think that we want to be able to help fill in. And we don't have to be the only ones doing it, but we can help facilitate that. We can work with other partners who are also providing board education. We can point you to resources. But we're raising our hand saying, we're here to help. So if you have specific observations or specific requests about board education, or about anything that you think we might be able to do to fill in a gap that somebody else is not filling in for you, this would be a great opportunity to do that.